that, we will try to just see as to how we can take that learning forward in the patient whom we see tomorrow morning in our clinic, right? Is my screen visible and am I audible?
Yes, sir. Yes, sir.
Oh,
All
thank
good.
you. Thank you.
Yes,
Fine.
sir. Yes.
So, thank you. So the topic is implications in clinical practice of the data that we have learned. What you see on the screen is Santander, which is the leading most bank in Spain. Santander's CEO in the year 2009 did a very unusual thing. He went on to let his staff go and join a study called PISA. PISA is a progression of early subclinical atherosclerosis. The PISA trial started in 2010. The PISA, you would remember that is the same line of MISA, which was Dr. Valentine Fuster's baby, and that had shown a lot of new data. In the same line, Santander CEO wanted its employee to join the trial. And that was started in 2010, moved down on to 2019 when the data was analyzed. Now, this is how it went. This is something very interesting. And this is, so it was done with the employees of State Bank of Madrid, Banco Santander. 4,184 staff of this bank, aged between 40 and 54, because 55 they were retiring, asymptomatic, there are absolutely no symptoms, no past CV disease. In fact, those who had some CV disease were excluded. And of course, they had an extensive workup of vascular system. They had a vascular ultrasound, a vascular CT, looking for vascular atherosclerosis. And whenever some degree of asymptomatic atherosclerosis was picked up, they had an MR to look into the amount of atherosclerosis, and also if there was atherosclerosis, FDG PET to look into the functional status of this atherosclerosis. Was there inflammation, no inflammation? So these are asymptomatic people like you and me, going around 40 to 55, 54 years, got told and had an extensive vascular investigation done. And let us see what happened. Okay, right. So this is what came out. And this study came in 2019 in JACC. There's a central illustration. You can see that when they looked into the MR pictures of atherosclerosis, you see it ranged between 53 and 73%. Whether you look at the cerebral, whether you look at the thoracic, whether you look at the peripheral vascular. Okay, but then we know that atherosclerosis is an age-dependent process. My vascular system at 40 is not what it is now, and it won't be same when I'm 80, right? But the interesting thing is when they looked into the functional aspect, they found that ranging from about 10% in the thoracic aorta to about 15 and 25% in peripheral vascular, there was features of inflammation. So not just atherosclerosis, a lot of these people had inflammation, active inflammation by FDG PET going in their atherosclerotic plaques. So these are people like you and me, healthy, going around without a problem. And investigation picked up, they not only have significant amount of atherosclerosis in multiple vascular territories, they also had inflammation. And that is the concept of polyvascular disease. Polyvascular disease, which means symptomatic, asymptomatic. But the point is polyvascular disease exists, and most of us in our clinical practice, we don't pick them up, right? Now, this was looked into the Euclid data. The Euclid data looked into polyvascular disease and the risk of major adverse cardiovascular events. That came in JAMA Open. Now, the Euclid trial had 13,885 patients. They looked at polyvascular disease. There was 20% peripheral arterial disease. CAD was PAD or CVD was PAD plus was about 30%. And the CAD, CVD, PV, PAD, all three was about 10%. So 10% had all three, cerebral, cardiac, peripheral, and 30% had dual, cerebral, peripheral, cardiovascular, peripheral, and 20% had pure peripheral arterial disease. And what is interesting is that they found that if you look at MACE, for example, okay, and look at those who had that gray line is peripheral arterial disease only. Of them, they did the best. And who did the worst? Those who had all three vascular-related disease, polyvascular disease. Polyvascular disease has the worst outcome when you look at MACE. What about cardiovascular death? Same, polyvascular disease was on top. What about myocardial infarction? Top. What about ischemic stroke? Highest. So this is something we were not realizing, right? So polyvascular disease, when there's a disease of cerebrovascular, cardiovascular, and peripheral vascular, we have the worst long-term outcome. And in our clinical practice, do we care? Right? I'm a cardiologist, you are all cardiologists, we look at coronaries, we fix them, put a stent, come out very happy. We are not looking into their peripheries or their cerebrovascular disease. The neurologist who treats stroke at best takes an EKG and doesn't bother with peripheral vascular disease. Our podiatric surgeon doesn't work up for coronary artery disease, right? And not just that, the points are what? Cardiovascular death, myocardial infarction, ischemic stroke, and the first one is MACE. So every parameter is worse when we have polyvascular disease, and that is learning number one. Now, the central picture of this Euclid data shows that, okay, you have cerebral, you have heart, you have limb, and they put a very beautiful picture. So the orange bar is a coronary artery disease diagnosed as stable angina, maybe prior unstable angina, MI, or a prior coronary vascularization, right? The blue, the green is lower extremity peripheral arterial disease. Could be presenting with interventional claudication or an ABI, which is less than 0.9, or a prior history of lower limb ischemia or amputation. Cerebrovascular disease may be prior stroke, TIA, carotid stenosis, or prior carotid revascularization. You see, they overlap. They overlap. And now, if you put the data that we, for example, learned from the REACH registry of 45,000 patients, what did we learn? 4 years follow-up. 1 in 6 had polyvascular disease in REACH registry. 1 in 6, right? Okay, look into peripheral arterial disease. The moment you have a peripheral arterial disease, you detect a peripheral arterial disease clinically or by an ABI, you know that there is a 40% chance of polyvascular disease. So the moment in the clinic you find that this peripheral pulse is dorsal species or the posterior is feeble, or he has claudication, he has ABI, which is abnormal, this man has 40% chance of polyvascular disease. And this man has the highest risk of everything, MACE, MI, stroke, right? So we are talking about a very high risk population. So I think if we are going to learn something from today's evening, Chuck, about the patient that we see tomorrow, it of course, one is dual pathway inhibition. That's a new concept, yes. That means a single antiplatelet, we went on to dual. From dual, we developed newer and newer antiplatelets, clopidogrel, ticagrelor, prasugrel, we added them up, increased the timings, increased the dosage, but we didn't do much, right? And today we are talking about, for example, newer trials, Twilight trial, we are trying to cut down on the dual antiplatelet, only ticagrelor, so that the bleeding comes down. And in that background, dual pathway inhibition of inhibiting thrombin also with a small dose of rivaroxaban is truly a concept change, not just scale change, but a concept change. But secondly, we should understand that we are missing something, and that is polyvascular disease. See, whenever we see coronary artery disease, how do we estimate their risk? We say, when did you have an event? If it is very close to an event, you are high risk, right? We give them dual antiplatelet, maybe an antithrombotic, very close to event, recurrent event, number one event. Second, what? We look at the extent of vascular disease. Multiple arteries are blocked, right? Coronary artery, multivessel disease. So compared to single vessel, oh, he has bad disease. LV function, oh, poor LV function. That means the disease is bad. And of course, the risk factors. He has diabetes, hypertension, dyslipidemia. Oh, he has so much of burden of risk. His outcome is bad. So we look at the burden of risk factor. We look at LV function. We look at the extent of coronary artery disease. Okay, and we look at the event number and the distance of the timing when we see the patient from the event, right? But we all neglected polyvascular disease as a clinician. The whole purpose of this is, armed with the data that Dr. Dalal taught us, we should not miss out polyvascular disease. And if we do pick up, we should think that is our present day therapy enough? And do we need to graduate on to dual pathway inhibitors? This is a 56-year-old male, diabetic, hypertensive, smoker, doesn't care anything, has a strong family history. One day suddenly thought of taking an insurance policy, and that's how he came to a hospital. And the routine ECG was barely normal, 12 lead ECG. So they said, the insurance company said, do a treadmill. And on peak exercise, we found that there's significant ST depression in the lateral precordial leads and of course the inferior leads. There's an ST elevation in AVR. So we said, yeah, you have bad disease, you're significantly positive treadmill, and on recovery, it was a little bit of upsloping change was there. So we said, have an coronary angiogram. And he just vanished. Well, lost to follow, right? And then he now appears with severe claudication. This is now. And then he said, I'm ready for anything. Look at the coronary angiogram. The circumferential CTO and the LAD is so bad, right? What can you do? Nothing really. Diffuse disease. The RCA, bad disease. So medical therapy, right? And when we looked at the peripheries here, that is the knee joint, you can see the arteries are right beyond that. Not just they were full of thrombus, but they are all very badly diseased, right? So the point is this: when we are talking about vascular protection, right, in a patient who has polyvascular disease, let's say polyvascular disease, what can be offered? We can lower the lipids, like Dr. Dalal said, statins, the STMI, PCSK9 inhibitors, inclisiran. We can give vascular protective drugs. We can control their blood pressure, like ACE inhibition, beta blockade, the CCBs, diuretic. We can control the blood sugar well, especially with the new agents like SGLT inhibitors, which by itself has a vascular protective effect. And of course, we can give aspirin, DAPTs. So the question is, can we do something more? And we saw the answer in COMPASS that Dr. Dalal presented, that we can benefit by adding dual pathway inhibition. So the point is this: okay, all these years we are looking at the platelet. We were developing newer inhibitors beyond aspirin. We were trying to inhibit the ADP, the P2Y12 receptor. We tried to develop Vorapaxar, the protease receptor inhibition. But okay, we were stalled at some point of time because we were neglecting the larger picture. We were neglecting the huge picture and not focusing on thrombin at all. And today we have focused on thrombin so that we have rivaroxaban and the DOACs inhibit the thrombotic pathway so that we get benefit. So we are talking about a change of concept, whereby from we are not talking about, like has been shown by Professor Dalal, not about the AF-related stroke prevention by rivaroxaban, but vascular protection by rivaroxaban. This trial is already known, but we need to see the first page because this is a stable rivaroxaban, cardiovascular disease. This is the COMPASS trial published. We have seen all details of it, but understand that now with that background, look at the data, right? The inclusion criteria was CAD, PAD, CAD plus PAD, and even those who had CAD less than 65 years, they needed to have 2 vascular beds. So the main thrust of COMPASS, a large part of it was polyvascular disease. So see, the moment they had PAD, a large percentage would have CAD also. So CAD, PAD. And even though CAD less than 65 had at least 2 vascular bed disease. So we are talking about polyvascular disease. Okay. And of course, we have seen the data that compared to aspirin, the aspirin plus rivaroxaban glued showed a hazard ratio of 0.76. That is 24% risk reduction. And the concept of DPI came in, that we have already learned. We have not spent time on that. But this is important. The major bleed increased. I mean, let us be very clear. Whenever we add any additional antiplatelet, hike an antiplatelet dose, increase its duration, or add any antithrombotic whatsoever, warfarin, vitamin K antagonist, DOAC, NOAC, whatever, the bleeding will increase because we are adding an anti-clotting therapy, right? So bleeding increased. Yes, it did increase in COMPASS with an hazard ratio of 1.7, and the p-value is very significant, right? Now, when we looked into the fatal bleed, intracranial hemorrhage, and symptomatic bleed in critical organs, something that will make you feel guilty. Oh my God, why did I start it? Fatal bleed, ICH, and symptomatic bleed in critical organ. There was no difference. And that, I think, is a fantastic news. Fantastic news. Bleeding will increase. Anything that you add substantially, bleeding will increase. But the very fact that fatal bleed plus intracranial hemorrhage and symptomatic bleed in critical organ did not increase is something that gives an enormous amount of confidence to me on this therapy. And of course, this has been discussed. The net clinical benefit, that is MACE plus fatal bleed plus symptomatic bleed in clinical organ, is 0.80, significantly good, right? That we have already learned. So this is the European Society guideline that says that adding a second antithrombotic drug to aspirin, what was done in COMPASS, in a high ischemic event, risk is 2A. And if it is a moderate increase in ischemic event risk, it is 2B. So high ischemic event 2A, moderate ischemic event 2B. What is 2A and 2B? So let us see high ischemic event, what they meant by high ischemic event risk. That is diffuse multivessel CAD that we were talking about. Our patient has got multivessel CAD like we saw just now, the angiogram, with either of the one, either diabetes or recurrent MI, a peripheral arterial disease, or a CKD with a GFR of 15 to 50. Our patient had PAD. So typical, right? Typical patient. Diffuse multivessel CAD with PAD. And by moderate risk, we mean is any one of the following: either multivessel disease or diabetes or recurrent MI or PAD or CKD plus addition of heart failure. So we are talking about a jumble of the burden of risk. We are talking about heart failure. We are talking about diffuse nature of the coronary angiogram. We are talking about PAD. So any of these things we see tomorrow morning, I in my mind would think, is my therapy good enough? Or does it need a tailoring or a graduation onto addition of rivaroxaban? The COMPASS trials data, they looked into the net clinical benefit that came only recently in the circulation journal. We'll not focus on the factors that Professor Dalal has already said. By the time Dr. Dalal was talking, I deleted the slide, but this is important. Events prevented or caused in 1,000 patients. Once we see this graph, the whole concept tends to sink in. Look at that. These 3 bars are the 3 different timelines. 12 months, 24 months, 30 months, right? 12 months, 1 year, 2 year, and 30 months. Now, the blue segment, now that is the 0 is the baseline, right? Now, the blue segment is dark blue cardiovascular death, light blue stroke, and lightest blue is myocardial infarction. And then red boxes are symptomatic bleeding into critical organ or fatal bleed. So red is bad, blue reduction is good, right? And we have the baseline. So look at that. Compared to 12 months, the MACE benefit has what? More than doubled in second year. And look at that. In third year, the graph has got to what? Minus 24. So the event prevented out of 1,000 patients jumped from 6 to 16 to 24 or 26 in the third year. Okay. What about bleeding? We said bleeding would increase. Yes, bleeding did occur, but over time it did not increase. 12 months, 24 months, 30 months, slight change, nothing much. And that is something that excites me. Because we have a drug which even when we use for long term, 1 year, 2 year, 3 year, the benefits are increasing, right? So more and more strokes, myocardial infarction, and CV deaths are being prevented at the cost of a stable bleeding. So the bleeding episode does not increase. And I think this has come in COMPASS. For the first time, I think a trial has shown that over time, the critical and the major bleed does not increase. And that is very, very exciting news to me. Now, the same net clinical trial database, they tried to look into which category benefited the best. Now, my talk was what? Implication of the COMPASS trial. So these are the group that I'm going to prescribe addition of rivaroxaban vascular dose to aspirin tomorrow. And what are they? Look at that. When we took age less than 65, that dark lines, the separation is maximum. The middle 2 lines are more than 65. So it is in the younger patients, less than 65, that the curve separation, the net clinical benefit over 36 months is maximum. So if I choose a patient who is less than 65, more than 65, I will choose the less 65 patient because I know he would get the maximal benefit on addition of dual DPI therapy, that is dual pathway inhibition. What about vascular bed? Polyvascular or single vascular? Very clearly polyvascular, right? The polyvascular line difference is far more than single vascular bed disease. What about GFR? GFR less than 60 has the highest separation. What about heart failure? No heart failure. Heart failure has the maximum separation. Diabetes? No diabetes. Diabetes at the maximum net clinical benefit. So if we want to take home which patient we should prescribe a vascular dose of rivaroxaban, it should be younger patient a polyvascular disease, a GFR less than 60, a patient who has LV dysfunction or cardiac failure, and a patient who is diabetic. Simple. Diabetic heart failure, borderline renal function, polyvascular disease, young, no question. These are the categories who would benefit. And these are the patients whom in the clinic, which you try to translate Professor Dalal's teaching to us on to the clinical science. This has already been discussed. Putting into perspective ACE inhibition, lipid lowering, DAPT, and blood pressure lowering, we see that the benefit of COMPASS is massive. We're not spending time on that. It's already been shown. Now, this is important. Do realize this important point. On the left is reduction of ischemic risk, the orange bar. And on the right is increase in bleeding risk. Whatever therapy you use, as you increase reduce the ischemic risk, the bleeding risk increases, right? So we have to find the sweet spot between the bleeding risk and the ischemic risk, which offers the best possible way we can escape in our patient. We can give an anti-thrombotic therapy, anti-ischemic therapy, but should be least bleeding, right? And you see the blue and the orange curve meet somewhere around the COMPASS database. Okay, and that is an area where the sweet spot lies. So it is the COMPASS kind of patients, those diabetic, those LV dysfunction, polyvascular disease, those with a borderline GFR and age less than 65 who would fit into this bill and who would benefit with what we are talking about. So finally, take home the DPI therapy for whom I would consider for a patient tomorrow. One, a patient who has recurrent events. This is what we have learned over years, right? A patient who has recurrent events, maybe on a single or a dual antiplatelet, needs an antithrombotic, obviously, right? So event is important to me. Second, I would think about multiple risk factors. More burden of risk factors, they are likely to have a worse outcome. I'll consider a DPI, right? Especially when there is diabetes. Third, extensive CAD. The angiogram is very bad, right? You can't do an PCI or a CABG. What are we going to do? We should think about dual pathway inhibition. LV dysfunction, in addition to what we are talking about. Yes, obviously, we should think of dual pathway inhibition. And finally, something that we have put at last, but perhaps should have come first. That is the concept of polyvascular disease. Unfortunately, not just in India, everywhere in the world, we miss out on polyvascular disease because we have all become extremely focused. I look at heart, you look at neurologists, look at the brain. Somebody looks at peripheral vascular disease only. The diabetologist, recently we had a meeting, they look at foot ulcer, right? They're not looking at cerebral vascular disease. So the concept of migration of risk factors from the standard 4 on top to the addition of polyvascular disease. We knew about this, but we're not applying in clinical sense. And if we apply that sense, so tomorrow when we detect that there's a peripheral vascular disease, or a patient says, oh, doctor, I also have claudication. Normally we say, okay, chalo, take it. What is claudication? We are talking about angina and we are talking about big drugs, whether you can have a CABG or a PCI. What is this little claudication that matters, right? But that can decide his fate and the outcome. And whether we are applying in that particular patient a DPI might make a major difference in his long-term outcome. So safety signs have changed. It's not just seat belts and helmets for two-wheelers. It is today sanitizers and masks. So things are changing. And like it is said, that we should not be the last person to write an old medicine or the first person to write a new medication, but vascular protective concept with Rivaroxaban 2.5 milligram added on top to an antiplatelet. You know, whether the future, like Professor Dalal has shown, is going to be a small dose of Rivaroxaban along with an P2Y12 inhibitor, we don't know. But with COMPASS data, at least small dose of aspirin with small dose of Rivaroxaban of 2.5 BID looks a viable option right now in the category of patient we've just talked about. Thank you for your time and attention, and we would unshare the screen and give it back to Professor Dal.